All right, so let's go ahead and continue. While this was discovered in 1928, it wasn't really until the 1940s that penicillin began to be used, and this was essentially being used in World War II. So if you take a look at this poster, it says, "The faster this building is completed, the quicker our wounded men get penicillin. Give this job everything you've got." So essentially, they were building, if you will, laboratories so they could grow up this fungus penicillium, and then they could extract it and then produce the antibiotic penicillin. So we know that there were lots of wounded warriors, and of course having an antibiotic was a really good thing to have. Although I'm going to be honest with you, back then, and even in the 50s and 60s and the 80s, 1980s, people didn't really fully understand how antibiotics worked. So we're going to come back to that. Why are we in a situation where we are today, having this co-evolutionary arms race with our antimicrobials? Where did that come from, and all that? But anyway, so this is kind of an interesting take on history. So essentially, we know that discovery of an antibiotic really took a turn in how we began treating diseases or infections back in the 20th century. Okay, so the first antibiotic, penicillin, being isolated from the fungus Penicillium. Penicillium actually is ubiquitous. It grows everywhere. It oftentimes will grow on like oranges that you have that are rotting in your refrigerator. So the colonies can look kind of greenish color with some white, like puffy stuff or stringy stuff, and that is the mycelium growing. And so it's pretty common. Anyway, kind of neat. So antibiotics are originally metabolic products of bacteria and fungi. And what did I say? I said, hey, they're making their own chemicals to help them outcompete or grow in the presence of other microorganisms. Or in other words, they are inhibiting the growth of competing microorganisms in their habitats so that they can survive. Okay? And what are we doing? We are tapping in to the fact that they make those, extract them, purify them, and use them in a way that is going to kill I'm going to say bacteria in high numbers, because we can use those medications or use those antibiotics. Okay, so we get a lot of antibiotics from a couple of different genera of bacteria. So Streptomyces is the origin of the antibiotic streptomycin. And then we have Bacillus. So you may recognize the BAC, so bacitracin and things like that can originate from some antibiotics coming from the Bacillus genus. And there's two molds that we use. The first one you already know, Penicillium, and the second one, Cephalosporum. Cephalosporium. So you might have seen some antibiotics that have that root word in there, and we'll come back to a list of antibiotics if this is really intriguing to you. Okay, so here you are. Maybe you're my dad. We show up in the ER. He's all acting spacey and not like himself. He's got a fever. And when he coughs, it just sounds like there's just like gunk in there and fluid moving around. So, before a physician is going to start antibacterial therapy, the first thing they're going to do really is the diagnostics, right? They need to do some imaging. They need to collect some information from the patient. So they do these things, and they have to essentially work through some diagnostic criteria or differential diagnoses to figure out what is the most likely culprit of their infection. Now, if you're in a waiting game, which is sometimes the case, they will give you a broad spectrum IV antibiotic in the hospital. If you're presenting with a sinus infection and I think I had a sinus infection when I was like 8. And then I had my tonsils and adenoids out, so I haven't had a sinus infection since. But if I had been taking a lot of antibiotics for sinus infections, then they may already know, well, let's go with something that's a little bigger guns. So they may not go with the true broad spectrum. But for most of us, you walk in, you have a sinus infection, you haven't had one in 20 years, they're probably going to give you a broad spectrum antibiotic. The best way to know or to determine what kind of antimicrobial to give a patient is direct examination of bodily fluids, sputum, and stool samples. Okay, so maybe you've been asked to give a urine sample. I know my dad had to. You might be asked to, cough up sputum, and of course they're going to take blood, right? So if you're in a office setting, you're probably just going to get an oral antibiotic, and essentially they're going to say, hey, if you're not getting better after 7 to 10 days, if your symptoms worsen, if you spike a fever, these kinds of things, then you may need to have a different antibiotic. But in general, in a hospital setting, they will oftentimes do the culture and sensitivity. So essentially what they're doing is they're going to grow up the bacteria that might be present in, sputum, stool, whatever, and they're going to subject it to different kinds of antibiotics to see which one's actually killing the microorganism that you have. And then in that case, what they're going to do is they're going to give you a narrow spectrum antibiotic that targets the thing that you have. And that really is the better way to do it, because think about it. You've got bacteria, particularly in your large intestine. And anytime that we're giving you a broad spectrum antibiotic, it's likely going to kill off mass quantities of bacteria in your large intestine. Now, there are some antibiotics that are targeted. So, for example, if you do, in fact, like I had, SIBO, small intestine bacterial overgrowth, they gave me an antibiotic, rifampin, that literally, is that what it's called? Cefaxin? I think it's the same thing. That literally would target the intestinal lining of the small intestine. So I didn't have to worry about my large intestine being infected or bacteria in my nasal passages and so on. But we have to be really careful about using broad spectrum antibiotics, because we can cause people to be open to what is the word I'm looking for? Opportunistic infections. Okay, so which is why some people who've been on antibiotics for long term are at high risk of being invaded by Clostridium difficile or C. diff. Okay, so moving on. So testing for drug susceptibility. So this is part of that sensitivity part. So culture and sensitivity. So for these particular organisms, because we are running a bit of a race with them, Staphylococcus species, so think Staphylococcus aureus, for example. So when we talk about staph infections or virulent staph infections, we really need to make sure we know what someone has rather than just throwing things at it, because there are many resistant staph species. The next one is the causative agent of gonorrhea. So Neisseria gonorrhoeae, that's another one. Enterococcus faecalis, and then any aerobic gram-negative intestinal bacilli are other bacteria that really need to be, the culture and sensitivity needs to be done, so we're not just throwing our broad spectrum antibiotics at them and potentially causing more resistance. Okay, moving on. All right, so this just shows us some disc diffusion plates. So essentially what we have here are antibiotic discs. They have different antibiotics on them. And here we have what we call a bacterial lawn. So that's the causative microorganism causing your infection. And then, so essentially we have these impregnated paper discs with different kinds of antibiotics, and we want to take a look to see whether the antibiotic is killing the bacteria on that agar plate. So what we see here is that there's a very nice zone of inhibition here on the lower left side. If you imagine this like a clock, this is like 7 o'clock. Then we see the one over here about 3:30, pretty large zone of inhibition. We definitely see some smaller ones, but what we want to do is we want to use the antibiotic that is causing the most death of that bacteria. And we're doing this, of course, on this agar plate. So that's definitely one way to first determine how well it's going to kill the thing that your patient may have. Okay, so I think I might have hit a lot of these things. Let me move my face. All right, careful history, pre-existing conditions that might influence the activity of the drug or the response of the patient. So that includes allergies, that includes liver and kidney disease, and then where you are in your stage of life, right? So we don't really want to be giving our infants high doses of antibiotics, and certainly don't want to use narrow spectrum antibiotics if we don't have to. Elderly are going to process those antibiotics a bit different. Pregnant women, there could certainly be effects on the developing fetus, so we want to be careful of that. Intake of other drugs that can result in toxicity or failure of one or more drugs. So we want to think about what else they're taking. And then, of course, there's this thing called drug-drug interactions. So drug combinations can have synergistic effects. So you may have to have a lower dose. Even as you age, you may have to have a different dose than you did when you were in your 20s, simply because of how our livers and kidneys are going to process those medications as we get older. All right, so what is the goal of antimicrobial drugs? You probably already know this, but we're trying to disrupt the cell processes or structures of our microbes. So we have bacteria, fungi, protozoa, as well as helminths, which are worms. We're also trying to disrupt virus replication. So we're going to have to target something about that virus, again, that allows it to kill it, which is kill it and not harm our own cells. Some of those medications can interfere with the function of an enzyme that microorganism needs to synthesize or assemble its own macromolecules. So we're just sort of disrupting its ability to carry out metabolism and, at least with our eukaryotes, homeostasis. So we can also target and destroy structures already formed in the cell, so those cells just simply can't live. So we think about this term, I believe it's on your study guide, selective toxicity. So we want to kill or inhibit microbial cells without damaging the host tissues. So we started this presentation sequence talking about that. We want to direct this to we want the chemical to be toxic to the disease-causing microorganism, but we don't want to be toxic to your own cells. So let's take a look. So here's some primary sites of action of microbial drugs. So if we just start over here, top left-hand corner, we have a number of antimicrobials that essentially are going to target protein synthesis. And they're doing that by acting on the ribosomes. Now, we also have ribosomes, but what you should know is that the ribosomes of bacteria are different. Like chemically, they are different. So we can essentially target the site of action of our antimicrobials to one of the subunits that make up the ribosome. So the 50S subunit, we have 3 antimicrobials here, and then there's another 3 plus a subcategory here, streptomycin, that's going to target the 30S subunit of the ribosome. Do you need to know what 50S and 30S are? No, but we got a bigger one. You see it's here on top, and we got a smaller one. It's here on bottom. And what these ribosomes are doing is helping us convert essentially messenger RNA into protein. Okay, and there's one that actually can target both of them. Let's go over here to the right-hand side. There are cell wall inhibitors. So you might remember, bacteria have special cell wall properties. And so some of those bacteria, like gram-positive, are going to have the lipopolysaccharide layer. Gram-negatives do not. So essentially, we can capitalize on those features and essentially have antibiotics that are going to target, in this case, I'm going to say the cell wall, right? So penicillin, cephalosporin. Remember, cephalosporin comes from the fungus Cephalosporium. Carbapenems, vancomycin, bacitracin, again coming from Bacillus, bacterial species, and then the last one there. Okay, so we also have these antimicrobials that target the cytoplasmic membrane. So it causes a loss of selective permeability, so not allowing it to send things in and out like it should. So it builds up in some chemicals and causes that to be toxic to the cell. Over here, folic acid synthesis in the cytoplasm. So we know that microorganisms are usually making folic acid. So we're going to block those pathways and inhibit the metabolism, and so then they die. So these are some of our sulfur drugs. So you might have heard of them. We will start in a minute.